afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on opioid toxicity among Ontarians who worked in the construction industry. My name is Pamela Weiss. I'm a public health physician at Public Health Ontario, and I have the pleasure of moderating today's session. For housekeeping, before we begin, a few items to mention. The chat pod is disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session, and we'll hold a discussion period following the presentation. If you have technical issues at any point, you can email capacitybuilding@oahpp.ca. As the moderator of this session, I don't have any conflicts of interest to disclose. For acknowledgements before we begin, I want to acknowledge and give respect to the lands, sky, and waters we share in Ontario that support us all, and being the traditional territories of diverse First Nation, Métis, and Inuit people. We acknowledge and respect everyone here today as we create a safe space for us all to learn and share together. And we honor the shared Indigenous knowledge and wisdom in guiding us in discussion on this topic and our commitments to action for the mutual benefit of all in Ontario. We also acknowledge the strengths, innovation, and leadership of people who use drugs in communities across Ontario, particularly as we approach International Overdose Awareness Day tomorrow, and its focus on time to remember and a time to act. Given the heaviness of this topic, please take care during this session and step away or reach out for support as needed. The objectives of today's session are to describe the demographic characteristics, circumstances of death, and patterns of healthcare and medication use among people who worked in the construction industry, summarize root causes, contributing factor, and the role of the health system in opioid toxicity deaths among people who worked in the construction industry, and opportunities to improve strategies to better meet the needs of people in the construction industry who use drugs. It's my pleasure to introduce the speakers for today's session, Tara Gomes, Nick Boyce, and Jace Watford. Tara is an epidemiologist and principal investigator of the Ontario Drug Policy Research Network. Nick Boyce is the director of the Ontario Harm Reduction Network and has served in various leadership roles in policy development, program implementation, and research. And Jace Watford has worked as a laborer, battled addiction, and is currently a frontline social service worker and university student. So I'll turn it over to Tara for our presentation. Thank you for joining, everyone.
Thank you, Pam, for that introduction. I'm very happy to be here today to speak about some of this work that myself, Jace, Nick, and others have been working on over the last few months, and to try and have these discussions to best understand how to support people who are working in the construction industry who use substances. Before I get into the data, I think it's really important, and we wanted to make sure that we took the time to recognize that embedded within the data and the numbers that we are reporting here are really the stories of so many Ontarians who have lost their lives to the ongoing overdose crisis. And we really want to acknowledge all of the friends, family, and loved ones of people whose lives have been lost to opioid toxicity deaths in Ontario, and recognize that this report really cannot reflect the burden borne by everybody who is being impacted by this crisis. We are required to provide disclosures. None of us have received any financial support from commercial sponsors, but we do have some conflicts of interest to declare, which are listed here. Largely publicly funded support for our research program or for stipends for involvement in some of the research that has been conducted. And so to mitigate this bias, this presentation did undergo peer review to make sure that we were being as objective and balanced as possible when presenting these findings. So this work really started when we released a report back in 2021, where we were using data from the coroner's office to understand how opioid toxicity deaths and the overdose crisis had shifted during the pandemic. And some of the information that is gathered during coroner's investigations is the industry within which people have worked, as well as whether they were employed at time of death. And in that report, we found that among people who were employed, 1/3 of opioid-related deaths occurred among people who were working in the construction industry. And this really aligned with other reports that came from elsewhere in Canada and made us pause a minute and think about how we could better understand the circumstances and the needs for evidence within this population to see where there are opportunities for response and how we can make sure that, as we know, this is a very complex issue and the overdose crisis is really multifaceted. So to think about how we can specifically generate evidence to inform what is happening within this industry. And so, as Pam mentioned, this report really focused on a few different areas, including what substances were involved in these deaths, what were the circumstances around the deaths where there might be an opportunity to understand opportunities for support and intervention, and then what are the other comorbidities or clinical diagnoses people might have, and are there indications of challenges accessing healthcare that could also be addressed. We, as I mentioned, used data from the coroner's office to do this. We looked at all people who died of an opioid-related toxicity across Ontario, and we looked at those who are either currently or previously employed in the construction industry at time of death. And we were pretty broad in the definition of construction to include the trades, equipment operation, general laborers, as well as thinking about formal and informal roles, as well as seasonal and temporary work. And what we did was then look at a comparator group of all other individuals in Ontario who died from an opioid-related toxicity who were not employed in the construction industry, based on that understanding of the coroner at time of the death investigation. And we linked this data to a number of different health databases at ICES to understand physician services, prescription medications people received prior to death, as well as recent engagement with hospitals and emergency departments. So this is what we found in terms of the trends in opioid-related deaths over time among those working in the construction industry. Broadly, what you can see is the blue bars represent those people who died who were working in the industry, and the gray shaded area represents the broader provincial trends. And you can see that there's a lot of alignment with those trends over time. And in particular, that during 2020, when the COVID-19 pandemic arrived in Ontario, there was this rapid acceleration in the number of opioid-related deaths that occurred both broadly in the province, as well as specifically among people working in the construction industry. So you're right in that it is a very high proportion, and it is 1 in 13. So about 8% of the opioid-related deaths that occurred in this timeframe were among people who were working in the construction industry, either currently working at the time of their overdose or they were previously construction workers. And I think it's important to think about the fact that this represents 366 lives that were lost who were construction workers. And the rest of this presentation is really going to focus on understanding some of the circumstances around those 366 lives. Very quickly, one of the things that we do see is that a majority of people, almost 60% of construction workers, were employed at time of death. And that is very different from what we see in the rest of the population of people who have opioid toxicity deaths, where there's a much higher proportion of people who are unemployed at time of death. But also we saw some interesting or important changes over time, particularly during the pandemic. I think that the construction industry was one industry that was largely spared in terms of having fewer shutdowns than perhaps other industries. But even with that, we did see a reduction in the percentage of people who were employed at time of death in the construction industry in 2020, which may reflect some of the challenges and disruptions that could occur with employment during the pandemic. We also saw that in terms of demographics, a lot of the overdose deaths that occurred within the construction industry really overlay quite a lot with the demographics of the people that we know are commonly working in this industry. So the vast majority of deaths that occurred were among men, 98% of them. And there was a very high concentration of these opioid toxicity deaths that occurred among people in the 25 to 44 year age group, which we know is also a demographic that is very commonly working within the construction industry. So we know, some of these basic elements of information about who is experiencing this harm. But in order to really inform a response, there are a few questions we still need to know. So, where are these services needed? Where are these deaths occurring? What kinds of services are needed? And are people experiencing barriers in accessing healthcare or other services that may be unique to this population and that we need to think about addressing when we move forward? So to start off with where services are needed, what we see is that the vast majority of the opioid toxicity deaths that occur among construction workers happen in Southern Ontario and in urban centers. And that aligns very closely with what we see among non-construction workers, which is the yellow bar in these figures, and also aligns with where we know the majority of the population resides. So these are trajectories and trends that we have seen in our past work. I do think it is important, though, to speak to the fact that while the absolute number of opioid-related deaths that occur in rural areas in Northern Ontario are lower because there is a smaller population in these parts of the province, when you adjust for population size, the rates are actually very high in rural Ontario and Northern Ontario. And so we can't forget about the need for us to also think about providing access to services within all parts of the province, and not only focusing on Southern Ontario and urban regions. We also looked at where the overdose deaths were occurring, because it's really important when starting to think about where do services or supports or intervention need to happen. And we found that about 80% of opioid-related deaths among construction workers were occurring within their private residences. And that is actually, even higher than what we see in the non-construction worker population. And we also looked at how many of these deaths occurred among people when they were on a construction site or in a hotel or motel that was used for work purposes. And those were very rare. So less than 2% of these deaths occurred in those situations. And I think that speaks to the fact that, while it's really important to put services everywhere, and there have been recent advances and movements to put naloxone in all workplaces within the construction industry, while I'm very supportive of getting naloxone into any place where we can get it, that is really not going to reverse the majority of the deaths that we are seeing, as they are largely happening when people go home within private residences. And that really raises the question of, where are those roles in providing those services and making sure that people are kept safe when using substances when not on a work site? And it also ties in with the question of what are those services that are needed, and how do we understand these driving factors? So one of the things we looked at was the types of substances involved in these deaths, and found that predominantly about 90% of these opioid toxicity deaths that occurred among construction workers involved non-prescription or non-pharmaceutical opioids. So these are drugs from the illicit or unregulated drug supply, which are primarily fentanyl and sometimes heroin. And I think that's really important because, sometimes there's a focus on discussing the role of prescription opioids and opioids used to manage pain within the broad conversations around this crisis. And it's really important to think about the fact that this is really something that is being driven by that illicit drug supply and what is a very toxic and unpredictable drug supply for people. And it's also important to remember that these are not deaths that occur with opioids alone, but very commonly have other substances involved. So we found that over half of the time stimulants were involved. Most of the time that was cocaine, but we also do see methamphetamines involved in these deaths. And cocaine there's a bit more of a propensity for cocaine to be involved in deaths among construction workers compared to opioid toxicity deaths we see among non-construction workers, which may tie in with the fact that they are more likely to be employed to perhaps be able to afford cocaine, and that might be just a stimulant that is more commonly readily available to them. And we also see that alcohol involvement is slightly higher as well within construction workers, with 1 in 5 of the opioid-related deaths also involving alcohol. So that is correct. So it's great that there's a real recognition of the fact that actually very rarely is there someone there who could intervene, and only in about 18% of deaths in construction workers was there someone present. It's also important to note that even when there was someone there to intervene, naloxone was only administered about half of the time. And so it again speaks to the opportunity for us to consider not only helping support people have ways in which to not use substances alone, to find people who would be able to intervene and to be able to call for help or administer naloxone if necessary. That can sometimes be virtually. There's been a real shift towards that in the pandemic of having more virtual intervention so that somebody is checking up on you virtually if they cannot be there physically present. But also think about how to make sure there's education and broad access and destigmatization of naloxone so that people do have naloxone on hand and can use it if they are there and witnessing an overdose. We also looked at how this changed over time, and we again saw these strange dynamics in 2020, where we actually saw a reduction in administration of naloxone among people who were there to intervene and witnessed an overdose among somebody who was a construction worker. And we don't know exactly what's driving those patterns. We did not see that among non-construction workers, but again, speaks to perhaps the need for us to think about how we continue that education and support for finding ways to get naloxone into the right hands and to have it in the right places for people to administer it when needed. We looked at a variety of other factors related to understanding what people's experiences were with pain, because we know that there is a close tie between management of pain and use of opioids. And broadly, we found that about 80% of construction workers who had a fatal opioid toxicity event did have a pain diagnosis in the last decade. And that's very similar to what we see among non-construction workers as well. We very often see pain diagnoses within people who experience opioid-related harm. Among construction workers, there was a higher prevalence of major traumatic injuries and traumatic brain injuries. So there are some differences in the kinds of pain and perhaps the chronicity of the pain or the requirements for long-term pain management. But we also saw that there was lower access to opioids to treat pain. So in the bar chart on the right, you can see that in the past month and year, there were slightly lower percentages of construction workers who had been prescribed an opioid compared to non-construction workers. And this really identifies the fact that there may be some barriers to people working in the industry who experience pain if they have expectations to work despite that pain, challenges having paid time off to recover that may lead to an over-reliance on that illicit or unregulated drug supply, which we know is very toxic and very dangerous. We also know mental health diagnoses are really common within the population of people who experience opioid-related harm. Among those who worked in the construction industry, just over 80% had some kind of healthcare encounter for mental health-related diagnosis in the last 5 years, which is similar, just slightly lower than what we see among non-construction workers. And these cross a variety of different diagnoses with a really high prevalence of mood and anxiety disorders, as well as substance use disorders. And I think we really just wanted to speak to this because it reflects the fact that people are often dealing with a lot. So there's a really high, it's very common for people to not only be experiencing pain, but also to be experiencing, depression or anxiety and trying to figure out how to access services. And this really speaks to the opportunity for us to provide a comprehensive scope of services and supports for people that include rehabilitation, that include pain management through prescription or non-prescription means, and other supports. And so that raises the question of how do we provide these services and how do we make sure that there are no barriers to their access? What we found when looking at recent healthcare encounters among those working in the construction industry who died of an opioid toxicity was that in general, there was slightly less engagement with the healthcare system compared to non-construction workers. However, there were still 1 in 4 construction workers who did have a healthcare encounter in the week before death, which really represents an opportunity for intervention and perhaps for better supporting people who are seeking help with physicians and in hospital settings, and there might be opportunities to engage them in treatment or harm reduction services or provide naloxone, which could better support them and help prevent some of these opioid-related deaths. We also found that about 3 out of 5 construction workers who had an opioid toxicity death had some indication of having a diagnosis of an opioid use disorder, which would mean that they would be eligible for accessing treatment with methadone or buprenorphine, which is an evidence-based treatment modality for people that can really help prevent overdose and stabilize people. However, despite that relatively high prevalence of OUD, we found that only 1 in 6 people with one of these diagnoses had accessed treatment in the month prior to death. And only about just over 1/3 of people had accessed treatment in the year before death, and that is slightly lower than what we see among non-construction workers. And I think ties in with some of the challenges as to how treatment is provided within our healthcare system. It's very strict, it's very regimented, and there's not a lot of opportunity for flexibility. And that can be very challenging for everybody, but also in particular for people working within this industry who are challenged with, having to be at different work sites, having early shifts or unpredictable shifts or long shifts. And so it can be very challenging to be at the pharmacy every day for your methadone dose if you're working in this industry, and speaks to the need for us to think about how we need to adapt some of these services. So just in terms of the main themes that we identified throughout this report, I know that Jason and Nick will speak to this more. Just very briefly, there are, I think, industry level responses that we need to think about that do extend beyond the workplace, despite the fact that many of these toxicity deaths occur outside of the workplace. There's a clear link between pain, between mental health diagnoses, between the ways in which people can or cannot access treatment. That means that there is a role for industry to be part of finding solutions and supports for people both within and outside of the workplace. There's also a lot of stigma that exists around accessing treatment for substance use disorders broadly within society, but also specifically within this population. And so we need to consider how to address that stigma and support people in accessing treatment or harm reduction, as well as understanding the risks of using multiple substances and using drugs alone, and find ways to help make sure that they have the supports that they need and have people available to them to intervene if they do experience a toxicity from the drugs that they're using. And finally, we know that there can be employment-related barriers to accessing pain management, to accessing treatment and mental health supports within this industry. And so identifying opportunities to remove those barriers and to help support people in accessing these various services is also really important. I'll just very briefly point you to this link, and we will put this link in the chat as well, which is an opportunity for people to access a number of different resources. There's an infographic with information that can be helpful to learn, as well as links to how to access different treatment and harm reduction services across the province. And finally, I just want to acknowledge everybody who contributed to this report. It was a real team effort of a number of different people beyond just the three of us presenting here today. Our contact information is here if people need to reach out. And I'd also like to acknowledge all of the people who use drugs and work in harm reduction, clinicians, peer support workers, and first responders who are continuing to really work tirelessly on this issue throughout the pandemic. And I want to recognize not only the trauma that they are experiencing, but also the enormous role that they are playing in helping to support people and keep people alive during this crisis. So now I'm going to pass it on to Pam, as well as Nick and Jace, who will be discussing some of the community response and lived experience.
Thanks so much, Tara, and thanks also for joining Nick and Jace for some moderated discussion about the report and providing your insights in the discussion. So the first question I have is for Jace, and I wondered, from your perspective, do you think the report reflects your experiences in working in the construction industry?
Thanks for the question. I definitely think it reflects, because I've been out of it for a few years now anyway. So I was hoping that with the changes that have happened with more drug awareness and how it impacts and affects individuals in the community, that the numbers would be lower. But I'm kind of shocked with just how much they've moved up. I find it a little more shocking, considering the advancements that we've made all over, that it's as if the information is out there, because anyone who's ever worked construction has an idea about this, because it's the substance abuse issues are not hidden. It's pretty much in the open, because if you work hard, you play hard. But it seems like it's okay for it to go on and continue to exacerbate.
Thanks for those insights, Jace. And then as we're doing our facilitated discussion, I wanted to invite people to keep adding to the Q&A pod as well for any of the panelists for our open Q&A afterwards. And the next question that I have is for both Nick and Jace, and I wondered from each of your perspectives, what are some root causes and risk factors contributing to these high numbers and rates of opioid-related deaths among construction workers in Ontario? And maybe Nick, if you want to comment first.
Hi, everyone, and thanks for having me. As Jace alluded to there, I think that there's many reasons here. One, Jace mentioned, it's a work hard, play hard culture. People in dealing with physical pain. I'll let Jay speak to some of that stuff there. So there's the culture itself, the nature of the actual work, but then there's also bigger, broader systemic issues around criminalization and prohibition. And I think one of the things that we've seen over the last few years and why these numbers are going up is also to do with the toxic illegal drug supply. As we saw in the data, this is not prescription drug use that people are dying from. It's because people are turning to the unregulated illegal drug markets for whatever reasons. And that has become so unpredictable, so volatile, so toxic. And that's what's killing people. And then the fact that people are using home alone. So things we can do to encourage people to use more safely and get people access to safer supplies, as well as different types of treatment options. Those are all things that we should be looking at.
Thanks, Nick. I'll turn it over to Jace for any other thoughts.
Yeah, I agree 100% with that. And there's another kind of anomalous sort of report that goes against my experience, where the deaths are alone. I mean, addiction wants to isolate and kill its user, right? But the lack of deaths that happen out of town, because in my experience, if I'm going out of town, I have no access to my dealer, or I have no access to my physician for a script. So I would be using the illegal drug supply if I was going out of town. So it's a lower number than I expected. So maybe that's a reflection of just the changes that have been made within the unions and companies and whatnot. But that's something that I picked up, because for me, if I was out of town, I was, spending half the time trying to talk to people to get some sort of fix, because my body's in so much pain, and then the mental anguish and anxiety on top of that was just pushing it even further.
Thanks, Jake. The next question is for Nick. And how are harm reduction programs and services in Ontario currently reaching and engaging people who work in the construction industry?
So for folks on the call that may be less familiar with what harm reduction programs are, these are services where we're working directly with people who use drugs in a non-stigmatizing way, recognizing that people use drugs for many different reasons. Not all drug use is addiction. Not all drug use is dependency. People use drugs sometimes to deal with physical and mental pain, but also just because drugs can be fun, they want to have a good time. If you just think about people's relationship to alcohol, we see people use alcohol in very different ways. So harm reduction programs recognize that, and they may be handing out needles, other equipment for people to use drugs. Nowadays in Ontario, we have drug consumption sites. So people may be coming into spaces, and we're actually letting them use drugs in those spaces. And in these programs, we're able to build supports and connections with people, and then offer them other types of services should they wish, such as other health and social supports. I'm not aware of harm reduction programs that are specifically targeting folks in the construction industry right now, but I can tell you anecdotally from my experiences working and going into some of those injection sites, I see a lot of guys in the trades and construction industries. And I know that, for example, some of the injection sites or safe consumption sites, they open earlier in the day just to allow guys to come in, use a bit, and then go on to that job. So I think there are opportunities, though, to think about how we can build awareness of harm reduction services within the construction industry, and also the construction industry itself. There's a tendency to think the solution to people using drugs is to get them into treatment and stop using. That works for some people, but not for everyone. So can we look at supporting their access to other types of treatment and other types of harm reduction services?
Thanks very much, Nick. Yeah, there was a comment in the chat box as well about sort of macho nature of the construction industry and money made to allow workers to buy. Someone else who had posted for the norris.ca around phone-based supervised consumption as well, which had been mentioned in Tara's talk too. So just moving to the next question for both Nick and Jace, how can industry and other sectors or services better support the needs of people who use drugs in the construction industry? And I'll pass it over to Jace.
I think there needs to be, because there's endless information available. I think that one of the biggest issues, especially that I have found, and it's going to return back to the macho kind of bit of a bro culture that's in the construction field, is it's a lot of men, and it's a lot of men who are discouraged from talking about what is wrong with them. So if my back is busted up, I'm expected to show up and do the work tomorrow, not complain about it. You can't show weakness. Trying to get any sort of support is usually discouraged or laughed at. Like we sacrifice our bodies to build highways, homes, hot tubs for everyone else, but there's not an open dialogue to talk about, what it's like for us, because this hard lifestyle deteriorates our family relationships, our friend relationships. I mean, I was living in a shelter for years, going to work, and I would go and I would be high while I was working, and I would do it and I'd come back home because someone had mentioned that there's money. So all my money was going into drugs, and I just stayed a shelter and I didn't really care about it. There's a lot of under the table work. People will come in and do it under the table. So there's no insurance on it. Like it's not the best environment for men's support through mental health and addiction. And like, I've lost friends that I didn't know were suffering. And it's because there's no conversation.
Thanks for your comments, Jace. Nick, do you have other insights for that question around support? And I also see that in the chat box, there were some videos shared from the community action team in BC around this topic as well.
Yeah, so I think just following up from what Jay said, firstly, I think, the number one barrier is stigma. That's drug-related stigma, and then also there's sort of toxic masculinity. So trying to make it okay for people to normalize the conversations without judgment. Also, just reflect on your own values around why you think the way you do about people who use drugs and their motivations for doing it. We've grown up in this criminalized prohibition context, and that's shaped our values and attitudes towards people who use drugs and certain types of drugs. There's no scientific evidence for why many drugs are illegal. These were based on racist, classist, social ideas. And many of these drugs actually can be used safely. We hear about all these fentanyl overdoses, but fentanyl is used every single day in hospitals. Alcohol can be a very dangerous drug, yet it's legal. Our values and attitudes are often shaped because of prohibition and criminalization. So I'd ask people to reflect on their values. Then let's start thinking about, what other supports we can provide people for mental, physical pain. It's very easy to also get, as I said, get people to start, just get them into treatment. We just need them to stop using, but abstinence-based treatment is available to many folks in the construction industry, but there's not a lot else for them. So can we look to other supports and other types of treatment? Flexible work arrangements in terms of giving people time to support their recovery from injuries. And then practical things like overdose prevention. So encouraging people not to use alone. getting access to consumption sites or supporting the consumption sites in their local areas, or virtual peer witnessing if we can't do consumption sites, and then providing access to overdose training and access to naloxone, and ensuring people have the access to naloxone when they're at home. And then maybe finally, access to safe, supporting access to safe supply alternatives. So we're looking at actually providing people prescription drugs instead of a toxic illegal supply. That might be a step for some people, a harder step to think about, but it's the reality of the world we're living in, given how toxic the supply is.
Thanks, Nick. That's a long list of ideas for people to consider. And then there was a comment in the chat about sort of managing impairment in the workplace as a part of this as well, those workplace policies. And we'll turn over now to the Q&A, and this is for all of our panelists. And I invite others to continue submitting their questions. So the first one is, do these data include individuals who had a history of work in the construction industry but left the industry long before they died? So I'll maybe turn that first to Tara, and then if Nick or Jason want to comment.
Yeah, thank you. And that is an important point. So what we did was include both, so people who are currently working in the industry at time of death and those who had previously been working. This data is collected by the coroners during their investigation. So it's not likely that someone who worked in the construction industry 10 years ago and hadn't worked in it for 10 years would be flagged that way, but it is collected data as part of an investigation. So it's not, I can't tell you exactly a time frame within which somebody would have had to have worked in the industry to be captured. The way we interpret this from our discussions with the coroner's office and looking at the data is that it would either be currently working in the industry or relatively recently having worked in the industry. And, you know, one of the things we know is that sometimes people who work in construction as general laborers will work for a little bit and then stop and then work, and it can be a little bit unpredictable, and, you know, shifts may not be consistent. It may be under the table, so it doesn't seem to be a formal employment arrangement. And so, you know, we wanted to make sure that we captured that when thinking about how we define this population, which is why we had a slightly broader definition than only looking at those currently working in the industry.
Great. And Jace or Nick, any other reflections on people kind of coming and going from the industry?
No, I mean, other than just, I mean, the answer, I think the answer is a lot of upstream thinking, and we really need to, I think, sit down and talk with a lot of the people that are involved, because it's, I mean, I'm extremely talkative and I'm willing to share my experiences, but most of the guys I know are not. And then you get the women that are in the field too, because they're so like, they're not equally represented. They speak even less, because it's a guy's culture.
Yeah, I think there's also supports for people when you have lost colleagues and friends. That impacts you as workers, as sort of brotherhood in some ways. So what kind of supports are we giving to family and friends of people that have died, but also just that are dealing with drug use issues? So I think there's other supports that we could look at there as well.
Great. The next question is, oh, it just switched on me. Are you familiar with other groups of professionals who are experiencing large amounts of opioid toxicity?
Do you want me to start, Nick, or go ahead?
Go ahead. Go ahead.
So from our perspective, I'll speak specifically to the data that we are able to look at, which is again based on these coroners investigations. There is no other industry that comes close to the construction industry. So we have a large number of people who are unemployed at time of death, or where we don't know their work situation, and so we can't say for certain. But among those where there is a known industry in which that person was currently or previously working, you know, retail comes up as, you know, which is a very generic setting. or industry comes up as one of the next top industries, and it is in the breadth of 5% of deaths compared to a third of deaths of the construction industry. So there is I think one of the reasons why us and many others have focused on this industry is it just seems like such an outlier when we look at the data. And I think that may be tied to elements of what we've just been discussing that are specific to injuries and workplaces that exist within this industry, but also the fact that it is an industry that is predominantly younger men, which we know is a demographic that is being disproportionately impacted by the overdose crisis broadly in Ontario. So I think there's some alignment there as well with the fact that there are just more at-risk people that are working in the construction industry.
Thanks, Tara. And Nick or Jace, do you have any other comments about professional groups that you see in your work?
None that sort of really jump out. I noticed there was a comment in one of the comments around the mining industry. I do remember going up to Red Lake, Ontario one time, and again, a work hard, party hard culture where you're down in the mines and working hard, but then you've got all this money afterwards and you just let loose. And they were seeing a lot of alcohol, cocaine, and steroid use was the other one. We don't talk a lot about steroids.
Yeah, I can completely back that up too. So I'm in the north, right? So I'm in Thunder Bay. So there's a lot of mining and that kind of work, and it's very similar to the work in Alberta that I was always around, which was fracking. So I mean, you're out for 2 weeks, 3 weeks. You come back for that week, and you have a bag full of money, and it doesn't usually go to where you really think it should go because it's work hard, play hard. But it's mining especially, and then the construction off times, right? Because a lot of individuals will work the entire season and then collect POGI, and so they'll be collecting unemployment insurance, and then that's when the bad habits kind of kick in and whatnot.
Thanks very much. The next question is for Jace. And just if you want to elaborate a little bit more on some of the solutions, what would help reduce deaths of construction workers from opioid toxicity? How do we connect people with services and remote supervised consumption, naloxone? If you wanted to elaborate.
Well, I mean, connecting with the individuals in there, because I believe that the unions, I believe that employers, they're fully aware that this is a problem. It should not come as a surprise. I think one of the big things I think is just what I'm noticing is with politics and elections and whatnot. So municipally, we've got two people that are new to Thunder Bay in the political scene, Lori Parass and Gary Mack, and they're both running, but their platforms are really loaded with opioids and getting beds and a lot of this stuff. And I've long seen that, like the last 8 years, the politicians are not really in line with what the people want. So now the people are speaking so much that I'm starting to see it. Like, I'm not a huge political guy, but if I'm seeing it in their platforms, that means it's noticeable to me. So that means it's noticeable to other people. So if we can have the branches of government working with the people, it forces everyone else to kind of like come in line as well too, I think. I don't know if that is the best answer, but sorry.
Thanks so much, Jace. The next question, there's a comment first. Thank you for an excellent talk. For those who wish to seek opioid agonist therapy, whether you have any comments on the acceptability of its use at work sites and arguments that are made about the safety of doing so. So maybe I wonder, Nick, do you have comments first on that? And then we'll go to Tara and Jace.
Sure. So for people not familiar with the term opioid agonist therapy, this is for people who are physically dependent on opioids. We can give them alternatives to drugs like heroin and fentanyl, such as you may have heard of methadone or Suboxone are the two primary ones we offer people. These drugs help you reduce the withdrawal feelings you get when those drugs are coming out of your system. They help stabilize people, and you don't have the same cravings for drugs anymore. There's many people can be fully functioning on methadone. Other people, it can provide some sort of impairment. So I think it's trying to find that right balance. The biggest problems with many of these programs is they're very restrictive in terms of when you have to show up and get your medications. You have to often go every single day. They have to observe you taking them. They're not at all flexible in terms of allowing people to get on with their lives. So I think we need, if we're looking at offering those kinds of programs to people, they need to be much more flexible. Some people just require simple dispensing of the methadone or Suboxone. That's all they need. Other people want or need other types of support along with that. So more a spectrum and more diversity within OAT programs is needed for sure. And I don't think it's an automatic, if you're on methadone, you can't come to work. I think it's an individual thing. Some people are going to need methadone so they can come to work, and other people, maybe they're not going to be able to participate. It's going to be an individual thing. Lastly, just in terms of the treatment options, again, in Ontario, many of the construction workers are sent to abstinence-based treatment that doesn't even allow for methadone. And that's a huge barrier. I'll just leave it at that.
Go ahead, Jace. I saw you off mute first, and then Tara.
I don't have a whole lot to add. Nick really checked off all those boxes. I as somebody who can speak to going to to follow that strict regimen of getting methadone, the way individuals get treated in those centers really borders on either really good or really awful, and I've experienced both ends of it. But to going into you need to do it because you need to take it, so you kind of you bite the bullet and you kind of sit in that stigma and the kind of the negativity that sits in there, because it's almost toxic in its own in its own right. But that, I think, is because you can't chastise people trying to get help, and you can't chastise the method of trying to help, because everyone that goes in there wants to be better. I don't know anyone who consciously wants to be addicted to anything. So, if we can make the experience better, then it would probably encourage more people to getting help and reaching out and asking for it.
Great. And Tara, any other thoughts on this one?
I think just to say that, it really came through when we looked at, in this analysis, of the types of treatment people were accessing. There was a slightly higher propensity for people to be accessing buprenorphine or Suboxone. That's the brand name version of it. And I think that's because buprenorphine, the way it's prescribed, people can more quickly get take-home doses. So by definition, it's a bit more of a flexible program where people can start to get a week at a time, not have to go to the pharmacy every day. So it makes sense that, there would be a little bit more of an acceptability or ability for people to remain in those programs. But we do know that people have different preferences. Some people don't like Suboxone, some people do better on methadone. And during the pandemic, we did see changes in take-home doses of methadone and more flexibility introduced, and some work that's being done across North America showing that broadly, that supported people staying in treatment and didn't lead to increased risks of harm like overdose by having that larger quantity to take home with you. So I think that it's, while the pandemic has been really problematic in this space for a lot of reasons, it has showed the opportunity and opened the door for us to think about more flexible treatment and to think about how we can improve the way in which we provide care to people through methadone as well as buprenorphine.
Great. As a follow-up to that as well, Tara, the next question is whether virtual care has improved access for workers. And I lose track of all of the studies that you're leading, but you might have some insights in this area.
We haven't done a ton of work on that. There was a shift to more virtual care for OAT early on in the pandemic. A lot of that has shifted back, but I think it can be supportive for people. For many people, they may not always have access to technology in order to access virtual care, so that can be a challenge. That may be less of an issue for people who are working in the construction industry, who might have the financial resources to be able to, have their phone and or access to internet to access these services. So I do think there's a real opportunity there, but we should make sure that we have multiple options available to people. So the virtual care as well as in person, to make sure that we are reaching as many people as possible. I don't know, Nick or Jace, if you have any more thoughts around virtual care.
No, just and specifically in terms of overdose and peer witnessing. So in many of the communities we're talking about where people are living and playing, we do not have supervised consumption sites. They tend to be in bigger communities. And even in the bigger communities, in places like Thunder Bay or Sudbury or London, even in Toronto, there can be stigma about going into those sites and people don't want to be seen in them. So could we offer virtual peer witnessing where people can actually be on phone or video with peers? And I see some people put numbers in the chats there, supporting alternatives like that as well.
Great. The next question, I'm not sure if I'm totally following the question, but I think how are harm reduction best practices, how do we educate employers and employees on harm reduction best practices in construction businesses? I hope I'm getting that intent right.
Can I answer that one? Well, I think it just simply, if we can stop looking at people who work in construction as disposable, as a disposable workforce, because it's not enough care is being spent. Even getting shoot, is it the labor board? Because even when you hurt yourself, there's still a ton of loops that you have to try and jump through just to get to support to prove that you're injured. So it's by that happening, that causes a lot of individuals to get painkillers from the illegal drug supply, because if they can't prove that like something's wrong with their back or they're considered to be drug seeking, this is like that. Just treat people like people and stop seeing them as somebody who's easily replaceable with the next young kid that comes along.
I would just add that if industry can in some ways support local harm reduction programs, because many of those programs are working on shoestring budgets already. The staff and the harm reduction community, people working in harm reduction, have been dealing with this for years now. They are completely traumatized and burnt out. It's hard to take on more work right now. And if there can be industry support for this kind of work, I think that would be really great.
Great. There is a few minutes left. I think there's the opportunity for any panelists who want to jump on a question to type an answer. I'll keep going with these. I'm not sure we'll get to all of them, but I think related to what you just said, Nick, are there supports for people who work directly in harm reduction industry? And it's hard to continuously deal with human suffering that seems never ending.
There's some pilot projects. There's a little bit of stuff happening in Toronto, but really there aren't the supports that are needed, and traditional employee assistance programs usually don't understand the kind of work that people in harm reduction are doing. So again, to support the workers doing the work, there needs to be more efforts made there for sure. I also just wanted to comment, there was a comment about developing training within the industry itself too. I've had conversations with people at the Ministry of Labor or other associations thinking about training. Please just engage people who use drugs in the development and delivery of those trainings. And I'm not talking about people who are in recovery. That voice is important too, but also people who are actively using drugs. You need them to help you deliver and design those trainings if they're going to be effective.
Thanks, Nick. I also saw that message coming in through some of the posts here as well. There's a question about if you have any information on Vancouver's Tailgate Toolkit program for the construction industry and thoughts about that and or something.
I would have to go look at that more. Thank you for bringing that to our attention. I think it's really important that we don't have to always recreate the wheel. There's lots of good stuff out there. And I know BC in many ways has been dealing with some of this stuff or more advanced in some ways. So I think there's a lot we can learn from BC. But Ontario is also has its own unique things. And I think we really have to scale up efforts in Ontario.
Great. The next couple of questions are, and we're coming down to our last question, so I'm going to get greedy and combine two. So whether or not there are ideas for engaging medical community, harm reduction community in the industry, and also advocacy with the College of Trade. So again, about some of those partnerships in order to move this move action forward.
Jace, do you want to go first?
Yeah, I mean, I think it's something that's pretty straightforward, and I think it's already happening. I mean, the more that we move away from the medical model of care and it becomes more holistic, that's where we'll start seeing greater changes. Because if we're just looking at everything from like the from a medical lens, we really negate the human being that's on the other side. So it's I think it's happening. I think we could speed it up, but I think it's happening.
Fully 100%, Jace. Thank you for saying that. You know, drug use is a health issue, but not necessarily a medical issue. And some people do want medical intervention, and we also need to do work within healthcare to address stigma, because there's a lot of stigma around drug use within healthcare. We saw 4 in 5 construction workers had some kind of interaction with the healthcare system, but that doesn't mean it was a positive interaction. So there's a lot of work within the healthcare system that needs to happen, but then broadening our understanding and thinking of drug use as not just a medical issue, but a broader health and social one, and then engagement with harm reduction programs, I think would really go a long way to opening up those ideas and conversations.
Great. I think we got to a lot of the points, and there were some links that were shared. We can summarize some of the information that came through on the Q&A, and thanks to our panelists and to everyone for participating today. And we'll wrap up the session with huge thanks to all of you here today. And just as another last housekeeping, you'll receive a rounds survey today to provide some feedback for evaluation purposes, and also you can access past PHO rounds and presentations on the PHO website. So thanks so much, everyone, and have a wonderful day.